A very good morning to all of you. It indeed gives me great pleasure to connect with all of you through this screen recorded lecture on cerebellum. It's been some time since we had a lecture session like this, almost a month ago. And due to this lockdown period, we were not able to connect properly with each other. But still, our academics should not get jeopardized. So we have to proceed with our academics, teaching sessions as usual. That's why active e-learning is going on now. Please make the best use out of it. And as a part of the other neuroanatomy topics, the topic for today is cerebellum. So today we're going to discuss in depth about cerebellum. It's a long question that can be asked in your theory paper. The objectives of this session will be that the student must be able to describe the cerebellum under the following headings: situation, external features, morphological subdivisions, internal features, connections, blood supply, comparator function and clinical anatomy of cerebellum. So these are the headings which can be utilized to structure your essay for a theory question paper. Let's move on now. Cerebellum is equally functionally significant like the cerebrum. That's why it is known as little brain. It is smaller in size when compared to cerebrum. Hence it is known as little brain. In Tamil, in local vernacular, we call it as Sirumulai, whereas cerebrum is known as Perumulai. Cerebellum is smaller in size, equally important, hence it is known as little brain or the Sirumulai. It is the largest part of the hindbrain, weighs 150 grams, situated in the posterior cranial fossa beneath tentorium cerebelli. Anteriorly separated from pons and medulla by the cavity of fourth ventricle. It is responsible for equilibrium, muscle tone and skillfully coordinated performance of voluntary muscular activities. In this picture you can make out the drawn picture above shows the cerebellum in purple color. The human brain specimen below shows the cerebellum in pink color. So this is a hand-drawn picture above and a true specimen below to show you how the cerebellum looks like. The cerebellum has very important connections with the brainstem. We know the three parts of brainstem. From above downwards, the three parts of brainstem are midbrain, pons and medulla. The cerebellum is well connected by means of cerebellar peduncles with the three subdivisions of brainstem. With the midbrain, it is connected through superior cerebellar peduncles. With the pons, it is connected through middle cerebellar peduncles. With the medulla, it is connected through inferior cerebellar peduncles. These peduncles are a pair, one on either side. So the cerebellum is connected with the midbrain through superior cerebellar peduncles, to pons through middle cerebellar peduncles, connected to medulla oblongata through inferior cerebellar peduncles. Now moving on to external features, it has three parts, two surfaces, two notches and three fissures. So these features will be studying one by one in detail now. Parts, it has three parts, right and left hemispheres and a midline vermis. The vermis is made up of a superior vermis and an inferior vermis. Superior vermis is continuous with cerebellar hemispheres on either sides. Inferior vermis lies deep in a sulcus known as vallicula. Surfaces, it has a superior surface and an inferior surface. Superior surface is convex from surface view. It has two cerebellar hemispheres continuous with each other. Inferior surface presents a deep notch known as vallicula that helps to separate the two cerebellar hemispheres. It has two notches as well. Anterior cerebellar notch accommodates pons and medulla, and the posterior cerebellar notch accommodates falx cerebelli, which is a small dural fold. Coming to the fissures, it has three major fissures which divide the cerebellum into lobes. Fissura prima, horizontal fissure, posterolateral fissure. Fissura prima is situated on the superior surface at the junction between anterior 2/3 and posterior 1/3. Horizontal fissure is situated between the superior and the inferior surfaces. Posterolateral fissure is situated on the inferior surface and its anterior end. Having gone through so many slides for the external features, let's do a quick recap of the external features once again. It's made up of three parts, right and left hemispheres, midline vermis, superior vermis and inferior vermis are the subdivisions of the midline vermis. Superior vermis can be seen from the superior view and inferior vermis lies deep in a sulcus vallicula. Two surfaces, superior surface, along which the two cerebellar hemispheres are continuous with each other. Inferior surface presents a deep notch where there is a vallicula that separates the two cerebellar hemispheres. Two notches, anterior cerebellar notch accommodates pons and medulla. Posterior cerebellar notch accommodates a small dural fold known as fox cerebelli. Three fissures which divide the cerebellum into three lobes. Fissura prima is situated on the superior surface at the junction between the anterior 2/3 and posterior 1/3. Horizontal fissure is situated between superior and inferior surfaces. Posterolateral fissure is situated on the inferior surface and anterior end. Now moving on to another important aspect of cerebellum, subdivisions of cerebellum. The anatomical subdivisions of cerebellum are anterior lobe, posterior or middle lobe, and flocculo-nodular lobe. In this picture on the right side, the cerebellum has been opened up so that the superior surface and the inferior surface can be seen in one surface view. Otherwise, normally when you visualize the superior surface, the inferior surface cannot be seen. Likewise, when you visualize the inferior surface, the superior surface cannot be seen. So the cerebellum has been sectioned in such a way, it has been sectioned and unfolded so that the superior surface and inferior surface along the horizontal fissure have come to lie in a single surface view. The anterior lobe is on the superior surface anterior to fissura prima. The dark colored area, dark red colored area, whatever lies in front of fissura prima, that is the anterior lobe in brick red color or dark red color. Posterior lobe or middle lobe is a part of the cerebellum that extends from the fissura prima to the posterolateral fissure, which is labeled at the bottom of the diagram. Flocculo-nodular lobe is the smallest one that lies on the inferior surface in front of posterolateral fissure. You can make out the dark brown colored structure there, like a small stalk and a flower, and that is the flocculo-nodular lobe. So anatomical subdivisions are anterior lobe that lies in front of fissura prima, posterior or middle lobe that lies between the fissura prima and posterolateral fissure, and flocculo-nodular lobe that lies on the inferior surface in front of posterolateral fissure. Subdivisions of vermis and hemispheres. The midline vermis also has subdivisions. These subdivisions are from before backwards: lingula, central lobule, culmen, declive, folium, tuber, pyramid, uvula, nodule. Pyramid can be called as pyramid or pyramis as it is labeled in this picture. I repeat, the parts of vermis are lingula, central lobule, culmen, declive, folium, tuber, pyramis or pyramid, uvula, nodule. So these are the subdivisions of the midline vermis. Parallelly, you have subdivisions on the cerebellar hemispheres as well. The anterior lobe has subdivisions as ala, anterior quadrangular lobule. The posterior or the middle lobe has subdivisions such as posterior quadrangular lobule, superior semilunar lobule, inferior semilunar lobule, gracile lobule, biventral lobule and tonsil. What is left separately as black color is a flocculo-nodular lobe, which is separate. It's a separate lobe by itself. So we have seen the subdivisions of vermis and the subdivisions of hemispheres. To repeat the subdivisions of hemisphere, anterior lobe is made up of the following subdivisions: ala, an anterior quadrangular lobule. Posterior lobe or middle lobe is consisting of the following subdivisions: posterior quadrangular lobule, superior semilunar lobule, inferior semilunar lobule, gracile lobule, biventral lobule and tonsil. So this is about the subdivisions of vermis and hemispheres. Now coming to subdivisions of cerebellum on a different note, that is morphological subdivisions. Morphological subdivisions describe the cerebellum with regard to the evolution of cerebellum, how it got evolved slowly from lower animals to what we are today as mankind or human beings. So morphological subdivisions are archicerebellum, otherwise known as vestibular cerebellum, paleocerebellum, otherwise known as spinal cerebellum, Neocerebellum, otherwise known as cerebral cerebellum. So archae, the word archae refers to archaeology, which means very old, digging up old things. So archae cerebellum is the oldest cerebellum that was existing in the lowest of animals. Vestibular word gives a clue that's concerned with balance or equilibrium. So archae cerebellum is concerned with equilibrium or balance of the body. Paleocerebellum is relatively newer when compared to archae cerebellum, otherwise known as spinal cerebellum, which means it's giving us a hint that it has more of spinal connection. So tone, muscle tone and posture is concerned with spinal cerebellum. Neocerebellum is the most recent one to have evolved in mankind, in primates and mankind, or cerebral cerebellum, which has more cortical connections to do much better skillfully coordinated muscular movements. So morphological subdivisions of cerebellum are archae cerebellum, known as vestibular cerebellum, paleocerebellum, also known as spinal cerebellum, neocerebellum, also known as cerebral cerebellum. Archae cerebellum concerned with equilibrium, paleocerebellum concerned with tone and posture, neocerebellum concerned with highly skilled performance of voluntary motor activities. Archae cerebellum or the vestibular cerebellum, phylogenetically it's the oldest part, as I mentioned to you just now. It's well developed in fishes and amphibians. Which part of cerebellum belongs to archae cerebellum? The flocculonodular lobe and lingula. So it has chiefly vestibular connections, which means it is mainly concerned with maintenance of equilibrium, tone, posture of trunk muscles. That means for balance. Paleocerebellum is otherwise a spinal cerebellum. It is next part to appear in terrestrial vertebrates with the development of limbs in reptiles and birds. So as the animal kingdom was evolving, the cerebellum was getting better and better in its function and structure. The anterior lobe, except lingula, but including the pyramid and uvula of the inferior vermis, will form the components of paleocerebellum or spinal cerebellum. It is concerned with spinocerebellar connections, which maintain tone, posture and crude movements of limbs. So paleocerebellum is the next part to appear in terrestrial vertebrates with the development of limbs in reptiles and birds. It includes the anterior lobe except lingula, but the pyramid and uvula of the inferior vermis has more of spinal cord connections to maintain tone, posture and crude movements of limbs. Neocerebellum is a recent one to have evolved, otherwise known as cerebral cerebellum, developed in primates along with enlargement of telencephalon and cerebral cortex. It's well developed in higher mammals. It consists of the posterior and the middle lobe except pyramid and uvula of inferior vermis. So it is consisting of the posterior or the middle lobe, but you have to exclude pyramid and uvula of the inferior vermis. It is mainly consisting of corticopontocerebellar connections to perform highly skilled, voluntary, well-coordinated motor activities. So these are the three morphological subdivisions of cerebellum: archae cerebellum, paleocerebellum and neocerebellum. Archae cerebellum, to reiterate once again, is concerned mainly with equilibrium. Paleocerebellum is concerned mainly with tone and posture of trunk muscles, and neocerebellum is mainly concerned with the performance of highly skilled, coordinated, voluntary motor activities. Coming to internal features now. We have done with the external features, moving on to internal features. Surface of the cerebellum is divided into numerous small lobules called folia by multiple fissures. So when you come to the dissection hall, you will find that the surface of the cerebellum has lot of small tiny fissures shown in the picture below, tiny fissures. These fissures, small fissures, will divide the interior of the cerebellum into small leaf-like structures known as folia. The external small fissures will divide the internal structure into small folium. Like cerebral cortex, you have a grey matter here on the outside known as cerebellar cortex and white matter inside. Submerged inside the core of the white matter are intracerebellar nuclei, or otherwise known as deep cerebellar nuclei. Due to the fissures, cross-section of cerebellum has a classical branching pattern of tree life known as arbor, vitae, cerebelli. The word arbor, vitae, cerebelli, arbor, vitae means arbor is tree, vitae means life. So branching pattern of tree of life in the cerebellum is known as arbor, vitae, cerebelli. So if you look at the red color marked area in the upper diagram, you can make out that's like a tree branching pattern which is known as arbor, vitae, cerebelli. This terminology I'm sure you heard in an earlier session in another organ when you were taught about or studying about another organ, and that is arbor, vitae, uteri. Arbor, vitae, uteri is a term given to the branching pattern of the cervical canal in the uterus. So in the picture on the right side you can make out the cervical canal, what is labeled as plicae palmatae. Plicae palmatae is nothing but the branching pattern of the cervical canal, and that is also known as arbor, vitae, uteri here. Tree of life pattern of the cervical canal of uterus. Just to compare and contrast that this terminology has another significance in another organ. So that's why I brought it here. So arbor, vitae, cerebelli and arbor, vitae, uteri have almost the same meaning, but this is in cerebellum and that's in the cervical canal of uterus. So please bear in mind the significance of both arbor, vitae, cerebelli and arbor, vitae, uteri as well. Now we studied that within the cerebellar cortex you have some nuclei. These are known as deep cerebellar nuclei or intracerebellar nuclei, dentate nucleus, emboliform nucleus, globose nucleus and fastigial nucleus are the names of these nuclei which we'll be studying now one by one. Intracerebellar nuclei, you have first the biggest one, dentate nucleus. It appears like a crumpled bag-like appearance. Hilum has an anteromedial position. It's largest and neocerebellar nucleus, which means it has more connections with the cerebral cortex or cerebrum. It's most laterally placed, responsible for skillful coordination of muscular activity. So anything which has more cerebral cortical connection is more responsible for skillful coordination of muscular activity. Connections of dentate nucleus, the neocerebellum will send its impulses to dentate nucleus. Dentate nucleus will further analyze it and synchronize it. It will process it and send it to red nucleus of the midbrain, from there to spinal cord or to thalamus and from there to cerebral cortex. So the dentate nucleus will decide what to do with the impulses it receives with the neocerebellar regions. Nucleus interpositus is a name given to two nuclei together, the globose and the emboliform nuclei. Emboliform is lateral and globose is more medial, mainly related to paleocerebellar cortex, so they are responsible for maintenance of flexor muscle tone. The connections of nucleus interpositus. Paleocerebellum sends the impulses to emboliform and globose nuclei, and these two will process the impulses and pass it on to red nucleus of midbrain and from there to spinal cord. The last nucleus now, fastigial nucleus, most medially placed nucleus, very close to midline, connected to archicerebellum, responsible for equilibrium, influences extensor muscle tone. So you can make out the fastigial nucleus close to midline as a medium big sized black color nucleus. The crumpled bag on the lateral most is your dentate nucleus, close to it is emboliform and very small is globose nucleus. So these are the deep cerebellar nuclei or intracerebellar nuclei. Coming to connections of fastigial nucleus, since we said it's concerned with the archicerebellum, the flocculonodular lobe, which is the component of cerebellum responsible for the older connections or oldest part of the cerebellum, sends the impulses to fastigial nucleus and from there to vestibular and reticular nuclei. Now coming to in general connections of cerebellum, the cerebral cortex, spinal cord, vestibular apparatus, red nucleus of midbrain, tectum of midbrain, all these will send their impulses to cerebellum to process them further. The cerebellum processes all these, senses these impulses, processes them, and then it sends out as efferents to red nucleus, thalamus, vestibular complex and reticular formation. Connections of cerebellum and the Functional significance of each of these tracts you'll be studying in detail in sessions in physiology. Coming to cerebellar peduncles, superior, middle and inferior cerebellar peduncles, what is contained within each of these peduncles, what are the tracts present, we are going to have a look at it now. Connections of superior cerebellar peduncle, the main efferent pathway of cerebellum, which means most of the impulses that are going out of cerebellum are going through superior cerebellar peduncle, which is connecting the cerebellum and the midbrain. It forms the main efferent pathway from cerebellum. Fibers arise mainly from the dentate nucleus. The afferents that are coming into the cerebellum through superior cerebellar peduncle are anterior spinocerebellar tract, tectocerebellar tract, trigeminocerebellar tract, cerebellocerebellar tract, hypothalamo-cerebellar tract. The efferents going out of the superior cerebellar peduncle from the cerebellum are cerebello-rubral fibers from globose and emboliform nucleus to opposite red nucleus. Cerebello-rubral refers to red nucleus of midbrain. That's why these fibers are from globose and emboliform nucleus to opposite red nucleus. Dentato-rubral and dentato-thalamic fibers to opposite red nucleus and thalamus. Cerebello-olivary fibers to opposite inferior olivary nucleus. Cerebello-reticular fibers from fastigial nucleus to reticular nucleus. So these will form the afferent and efferent tracts that pass through the superior cerebellar peduncle. Afferents are going into the cerebellum, efferents are coming out of the cerebellum. Connections of middle cerebellar peduncle. It has only afferents that is coming into cerebellum. Pontocerebellar fibers which belong to corticopontocerebellar pathway, reticulocerebellar fibers and ceratogenic fibers. In this picture you can make out where it is labeled middle cerebellar peduncle. So middle cerebellar peduncle brings in fibers into cerebellum. Pontocerebellar fibers, which is a part of the corticopontocerebellar pathway, reticulocerebellar fibers and ceratogenic fibers. It has no efferents passing through the middle cerebellar peduncle. Only afferents are entering the cerebellum through the middle cerebellar peduncle. Coming to connections of inferior cerebellar peduncle, the afferents, tracts that are passing as afferents through the inferior cerebellar peduncle are posterior spinocerebellar fibers, olivocerebellar fibers, parolivocerebellar fibers, curiocerebellar fibers, anterior external arcuate fibers, vestibulocerebellar fibers which form the juxtaversiform body, reticulocerebellar fibers. I am only mentioning the name of fibers because each of these tracts will be taught in physiology. The efferents that pass through inferior cerebellar peduncle are cerebello-vestibular fibers from ipsilateral, that means same side, from ipsilateral flocculonodular lobe and fastigial nucleus of both sides. Cerebello-reticular fibers from fastigial nucleus of both sides to brainstem reticular formation. Cerebello-olivary fibers. So this completes the connections of each of these peduncles. What are the afferent and efferent tracts that are passing through these peduncles? Coming to in general the main connections of cerebellum. So cerebellum has its inputs. The afferents are coming from cerebral cortex. You can just make out the tracts that are passing here in this diagram. From the cerebral cortex it receives inputs. Then it receives inputs from the other structures also, like red nucleus, a tectum of midbrain. It processes all these inputs and then it sends back these inputs to the spinal cord, and then it sends back the inputs to thalamus and from there to higher centers. So this is how the cerebellum functions. Comparator function is a very important function of the cerebellum. It plays a key role in accomplishing smooth and coordinated movements by its comparator function. What is this comparator function? Comparator function, it's like almost like working like a family, or almost like a family situation. You can see three components labeled here: cerebral cortex, cerebellum and spinal cord anterior horn cells. If you compare this with a family where we are all in now, cerebral cortex is like the father, cerebellum is like the mother, spinal cord anterior horn cells will be the children or a child, a single one or multiple, many children. So cerebral cortex is giving some money, some kind of lenience or liberty or money or cash to be utilized by the children or kids in the family. At the same time, the father is skeptical whether it will be utilized properly or not. So he wants to keep a check on the utility of the money or the way in which the children or the kids utilize the money given by the father. So what will the father do? He just tells the mother, hey, come on, Amma, please have a look at the children. I've given some 1,000 rupees money. You just have a look or monitor and see what they are using it for. Just keep an eye on them, watch them and monitor them, what they are using the money for. So the father is a cerebral cortex, the mother is a cerebellum, the children will be the anterior horns of spinal cord. So now what the cerebellum will do, any motor impulse given by the cerebral cortex to the spinal cord will be watched, supervised and monitored by the cerebellum. If it is not performed or enacted out properly, if the motor activity is not performed properly, the cerebellum will give the impulse again to the cerebral cortex. See, they are not utilizing money properly. You have to control them once again. So cerebellum gives this kind of impulse to the cerebral cortex. The cerebral cortex now alters. It alters the impulses given to the spinal cord so that the motor movements or motor activities get modified accordingly into a desired one. So this is the help given by the cerebellum. The cerebellum compares the intended movement with the actual movement occurring, and if a difference is detected, the cerebellum sends the information to the motor cortex and lower motor neurons to correct the discrepancy. Thus, the result is smooth coordinated movements, that is, movements produced are accurate in time, rate, range, force and direction. So with training, a person can develop highly skilled and rapid movements. The cerebellum thus plays an important role in learning motor skills. So that is how it has a comparator function which is not there for any of the other structures in the brain. So thus the cerebellum has a very wonderful and different kind of function known as comparator function. So whatever impulses or commands given by the cerebral cortex to the spinal cord, it's being monitored, scrutinized and information, if something goes wrong, is sent to the cerebral cortex. The cerebral cortex will receive that impulse from the cerebellum and again correct the motor activity or the voluntary activity done by the muscles by the impulses received from the spinal cord. So the desired activity will be brought in now by the correcting measures of cerebellum, and that is what we call as comparator function of cerebellum. So because of this comparator function, the movements now become accurate in time, rate, force and direction, and this is how a lot of activities which require skill. You'd have seen that the jugglers juggling with balls and bottles and all these performances that you see in magic show with cards, playing cards, they juggle with large objects like bottles or tumblers or balls. They juggle with 3 or 4, two handled by the hands and 3 or 4 in the air. So all these are highly skilled movements which can be done only if the cerebellar function is intact or the integrity of the cerebellar function is maintained normally, and that is what we call as, with training, a person can develop highly skilled and rapid movements. So thus the cerebellum plays a vital role in the learning of highly skilled motor activities. So having finished with most of the cerebellum, now moving on to the blood supply. Its arterial supply is the superior cerebellar artery, a branch of basilar artery. Anterior inferior cerebellar artery known as ICA, a branch of basilar artery again. Posterior inferior cerebellar artery, PICA, it's a branch of vertebral artery. So these are the arteries, main arteries supplying the cerebellum. Superior cerebellar and anterior inferior cerebellar are branches of basilar artery. Basilar artery is formed by the fusion of the two vertebral arteries on the basilar groove on the ventral surface of pons. Posterior inferior cerebellar artery is a branch of vertebral artery itself. The veins will be accompanying these arteries. Nothing special to mention about the veins. Moving on to the most important and very interesting part of today's session, that is clinical anatomy. Cerebellar lesions can be due to trauma, vascular occlusion, tumors, which will result in various signs and symptoms known as cerebellar syndrome. If there is involvement of archicerebellum, what is the function of archicerebellum that we studied? Equilibrium or balance. So if there is involvement of archicerebellum or the components of archicerebellum, those parts of cerebellum are involved in trauma, vascular occlusion or tumor, there will be truncal ataxia for the patient and staggering gait. Truncal ataxia means he will be swaying, he will not be able to stand straight or erect. Staggering gait, he cannot walk in a balanced way. Nystagmus, when you ask him to see this side, that side, you will be having involuntary to and fro oscillatory movements of eyeball. Romberg's sign is a sign when you ask a patient to stand with his eyes closed, he will sway to one or more side. He will not be able to stand straight with the eyes closed. With eyes open, okay, but with eyes closed also we should be able to stand straight, maintaining our equilibrium normally. So this will be the presentation of the patient, clinical presentation of the patient, if there is involvement of archicerebellum in trauma, vascular occlusion or a tumor of cerebellum. Truncal ataxia, staggering gait, nystagmus, positive Romberg's sign. If there is involvement of paleocerebellum, there will be hypotonia, asthenia, that is reduced muscle tone of limbs, flail joints, that is lack of stability of joints because there is no muscle tone for the muscles acting around the joints will go in for frequent dislocation, that is known as lack of stability of joints or flail joints. Anytime they will dislocate. Disturbances of tendon reflexes, if you want to elicit a knee jerk, there will be a pendular knee jerk. The patellar reflex results in oscillating movements of leg. There will be swinging movements of the knee leg at the knee joint. So disturbances of tendon reflexes will result in pendular knee jerk. Ataxia, he will not be able to stand straight, inability to maintain balance while walking, that will also be there if the paleocerebellum is involved. If the neocerebellum is involved, you will have asynegia, that means muscular incoordination. Dysmetria, pass pointing or finger nose test. If you close your eyes, stretch out one hand, stretch one hand out with the index finger with the closed eyes. Bring your index finger towards the tip of your nose and try to touch it. That is known as finger nose test. With eyes open, of course, all of us can do, but with eyes closed also, a normal cerebellar person should be able to do it. So if you have any problem or involvement of neocerebellum, the patient will not be able to close the eyes and touch the nose or tip of the nose with his own finger. This is known as pass pointing or finger nose test, and this condition where he is not able to do so is known as dysmetria. Intention tremors is a condition where when a person or a patient suffering from cerebellar lesion wants to pick up an object on a table or somewhere on a surface, as he goes close towards the object to pick it up, when his motive is to go and pick up that object, close to the object, he'll be developing tremors in the hand. So intention tremors, when there is an intention to do something, tremors will start appearing. So tremors occur during purposeful movements and disappear at rest. This intention tremors has a difference to be discussed with in case of tremors due to basal ganglia, which I'll be telling at the end. Dysdiadochokinesia, inability to execute alternating movements in quick succession. Pronation, supination of forearm. Now when we go and sit in a musical concert or in a dance concert, in a musical concert we all take our palm and keep on our thigh and thalam podum. So we'll be doing supination, pronation along with the music that we are listening to or in sync with the music that we are listening to. If you like it, you'll be vigorously putting thalam, that is known as thalam, on your thigh. On your own thigh you will be doing that movement. Your palm will be going this way, that way, that is supination, pronation, and your palm will be facing inward, outward like that. So that is dysdiadochokinesia, when you are not able to do such synchronous movements in quick succession. Dysarthria or scanning or staccato speech is slurred, prolonged, explosive speech with pauses in wrong places. The patient will not know where to stop exactly. He'll have a slurred speech and suddenly some words will very violently get blown out. So that is known as dysarthria, scanning or staccato speech. Rebound phenomenon is a very different kind of phenomenon where the patient is unable to check the action of agonist muscles by the corresponding antagonist muscles. Supposing you have your biceps, the flexor, and triceps, the extensor of elbow. To what extent the biceps is functioning or contracting, the triceps will know, because the next movement is going to be triceps. If you keep on flexing, after some time the triceps should be ready to extend. Likewise, if the joint is constantly extended, that is the triceps is contracting continuously, the biceps should know it should be ready to flex now. So that is known as to check the action of agonist muscles by the corresponding antagonist muscles. If a patient is asked to push the palm of a doctor by his palm, the force that the patient can develop slowly rises, and now if the doctor suddenly removes his hand, the limb of the patient flies back and hits against his chest because he is not able to stop his pushing act immediately. I hope you understand this point. The patient is asked to push the doctor's hand with the patient's hand. The patient with his hand should push the doctor's hand. The force with which the patient is pushing the doctor's hand keeps on rising, at which point the doctor removes his hand. Once the doctor removes a hand, the patient's hand will hit his own chest violently. That means his muscle groups do not understand what the other group is doing. The agonist group doesn't know what the antagonist group of muscle is doing, and the antagonist group doesn't know what the agonist group is doing. So this is known as rebound phenomenon. When you're going in one direction, suddenly you move violently in the other direction. So that is rebound phenomenon. So these are the clinical features with which the patient can present depending upon which part of the cerebellum is involved in the lesion, whether it is archicerebellum, paleocerebellum or neocerebellum. So this is a picture to show you how on the right side picture the patient is trying to do the finger nose test. The patient should close the eyes, go and touch the doctor's finger, come back and touch her own nose, tip of the nose. And here on the left side picture, the patient is supposed to keep both fingers straight, the index fingers, with closing the eyes. He should be able to touch, he or she should be able to touch the tips of both index fingers. One index finger should touch the tip of the other index finger, all this with the eyes closed. Of course, obviously with the eye open we'll be able to do it. The patient should be able to do it with eyes closed, only then you can detect or assess the integrity of the cerebellar function. So this is known as pass pointing. Cerebellar lesion signs and symptoms are on the same side, ipsilateral, as a lesion. Whichever side is affected, the same side you have lesions or signs and symptoms on the patient's body as well. Because cerebellar hemispheres are connected by tracts with the same side of the body, they do not cross. These tracts do not cross, so they are on the same side. Cerebellum and basal ganglia both control motor functions but have opposite effects. Because in a cerebellar lesion, there is reduced muscle tone, hypotonia, and intention tremors, whereas in basal ganglia lesion, there is hypotonia and resting tremors. Resting tremors means when the patient is sitting quietly also, there will be tremors of the hands. Not necessary he has to go and pick up an object. Even otherwise, even at rest, the patient will be presenting with resting tremors and increased muscle tone, which is known as hypertonia. So this is all about cerebellum. To have a quick recap, so you know cerebellum is otherwise little brain. It's situated in the posterior cranial fossa, and you have just weighs around 150 grams. It has three parts. I'm just going through it. It has three parts. The three parts are the two hemispheres, cerebellar hemispheres, and the midline vermis, which comes as superior vermis, inferior vermis. Then you have two notches, anterior cerebellar notch, posterior cerebellar notch. You have two surfaces, superior surface, inferior surface. Then you have three lobes. You have three fissures dividing the cerebellum into three lobes. The three fissures are fissura prima, horizontal fissure, and posterolateral fissure. Then you have the lobes, the anterior lobe, posterior or middle lobe, and you have the flocculo-nodular lobe. Coming to subdivisions, you have the morphological subdivisions or the evolutionary subdivisions as archicerebellum concerned mostly with equilibrium, paleocerebellum concerned mostly with tone and posture, and neocerebellum concerned mostly with the performance of highly skilled motor activities. So you have the connections. With the brainstem, it is connected with superior, middle and inferior cerebellar peduncles, one on either side. They are a pair. Each peduncle will be a pair, right and left side. And coming to the connections of the cerebellum are only through these peduncles. We've seen a whole list of all the tracts passing through these peduncles. If you take the interior substance, you find that the outside fissures will divide the interior into small leaf-like portions known as folia. And you have the grey matter outside and white matter inside. Within the white matter, you have embedded deep cerebellar nuclei known as intracerebellar nuclei as well. They are 4 in number on each side. The largest is the dentate nucleus, concerned more with neocortical connections. Then you have the emboliform nucleus, the globose nucleus, and fastigial nucleus. So all these have connections as well. The fastigial nucleus has more archicerebellar connections, and the dentate nucleus has more neocerebellar connections. Coming to blood supply, it is supplied by superior cerebellar artery and anterior inferior cerebellar artery and posterior inferior cerebellar artery. So all this is just to recap, and then we saw the comparator function in detail, how it's functioning as a mediator or as a middleman coordinator or controller when the cerebral cortex is giving impulses or information to the spinal cord to bring about the desired motor activities in the body. Whether these motor activities are being performed to the desired level, or they are overperformed, or they are underperformed, is checked by the cerebellar function. The input is given to the cerebrum, and the cerebrum will once again modify or rectify the motor activities brought out by the spinal cord. So that's about the comparator function, and then we've gone through the entire list of clinical presentation when each part of the cerebellum is involved in vascular lesion, tumors, or like that. So, and comparison about cerebellar lesion and basal ganglia lesion also has been adequately discussed and described. Now coming to medulloblastoma, it's one of the tumors of cerebellum which involves a vermis. It's due to a poorly differentiated neuroectodermal cells. Highly malignant tumor mostly occurs in children, and there will be signs and symptoms of cerebellar lesion in the patient. It's a very rapidly progressing tumor, and it's really very difficult to save the child. All these are developmental defects because it's due to poorly differentiated neuroectodermal cells. So that's about the medulloblastoma, which is a very rare kind of highly malignant tumor in children. So this is about the entire gross anatomy of cerebellum. Any of the subdivision can be asked for a short note question, and the entire session is for a long question. All the subheadings that we have discussed today can be asked as subheadings in a structured essay question in your theory paper for internals or for university exams. And for spotters, mostly for spotters, we keep the dentate nucleus. We pin the dentate nucleus, and we ask you to identify it. It's very, in a section of cerebellum, it's very well made out in a specimen of human brain. We'll teach you in the dissection hall after we get back to our routine usual classes whenever the college opens for students. So this dentate nucleus will be pinned, and its connections can be asked. Any sub question under that can be asked. Give any two connections of this, or identify the pin structure, something like that. The cerebellum itself can be pinned, and its parts can be asked, its blood supply can be asked, its function can be asked, or its fissures can be asked. So anything like that as a spotter can be asked for gross anatomy spotters. For discussion, the cerebellum can be given as it is, and the examiner will ask you to discuss the cerebellum with the examiner. So that is also possible for a discussion on a specimen of cerebellum. So this is about, and in exam point of view, theory, it's a very important essay question, spotters, and discussion viva. Histology of cerebellum will be taught to you on a separate session on histology. Microscopic anatomy of cerebellum will be taught on a separate session in histology, and I have not touched upon that today. So with this, I think we had a good detailed session about cerebellum and its clinical features up to its clinical anatomy, and how it can be examined in the form of theory exam or in practical exams. I think I've discussed enough now. So hoping to meet in another session like this with all of you, and hope you enjoyed this session. You can again and again go through this lecture and recap whatever you studied. Thank you for your patient listening, and we'll get back to you in another lecture session like this in the near future. Thank you. Have a great day. Stay home, stay safe.